Hi students, this is the HEENT presentation, brief lecture notes with a few slides on physical examination techniques. This week's content includes physical examination techniques and health assessment of the head, eyes, ears, nose, and throat body systems. This week's content includes the head, eyes, ears, nose, and throat assessment and a few slides on physical examination techniques. There are 4 types of physical assessment techniques: inspection, palpation, percussion, and auscultation. The lecture for this week includes content on physical examination techniques and equipment and the head, eyes, ears, nose, and throat body systems. There are 4 physical assessment techniques: inspection, palpation, percussion, and auscultation. And the order in which you perform these techniques is standard, and this is the order. There's only one body system that it is different for, and you will learn that when you do your reading further along in the semester. I consider percussion to be an advanced assessment technique, and I don't think most nurses perform percussion. I think it's more of an advanced nursing technique. However, you will be percussing Tina on Shadow Health. Inspection is the first technique used in physical assessment, and it's the only technique that's used for every body part. So you will always use inspection. You get a general impression of your patient. It always also helps you to visualize a specific body system, such as the skin, hair, and nails, or visualize any signs that may tell you about an internal body system. So as you know, we often look for color on the skin, but that tells us a lot about perfusion and cardiac output. There are certain things that can interfere with your ability to perform inspection. Certainly if the patient is completely dressed, you're not going to get a very good visualization of their skin. So depending on what you need to perform, you may need to undress your patient, and we always want to make sure that we only expose the body part that we need to see. It's especially true in pediatrics because children get very nervous when when you have someone take their clothes off. They're very uncomfortable, so we usually don't even do that for kids. We'll just lift up their shirt to listen and things like that. And also adolescents, because body image is a really important thing to them, and they're very modest. So it's important to, well, not all adolescents are modest, but they can be very modest, and so you just have to be careful about that. And just making sure that you check with the patient before you, remove any clothing or move anything. Also, if the patient is got some type of a device, such as a knee immobilizer or a cast or particular dressings, that's definitely going to interfere with your ability to visualize an area. Certainly, if you're trying to look at an IV site and it's quite covered, it's going to limit your ability to inspect that. You want to make sure you note that in your documentation. Otherwise, if there was ever a problem down the road, and you didn't say that you weren't able to visualize it, then you'd be held accountable for whatever the problem was. So the other thing is, while you're performing some tasks like assessing vital signs, you can be doing a general inspection of your patient. You could be looking at their physical characteristics, noting their facial expression, their level of alertness, whether they appear anxious or nervous. And then we move on to palpation. And there's different types of palpation. Generally, you're using parts of your hand. For fine discrimination, you just want to use your fingertips. Then you can use all of your fingers to press a little further along, depending on what you're feeling. If you're trying to feel something rather tiny, like a nodule or a bump, you might just use your fingertips. If you're trying to feel a larger area, you may use all of your fingers. And then for a greater area, you can actually use the palm of your hand as well. And you also want to make note that you're going to begin with a light palpation and then progress to a moderate or deep palpation, depending on what it is you are trying to palpate. Keeping in mind that if it's very uncomfortable for your patient with just a light palpation, you certainly wouldn't want to progress to a deep palpation and make them super uncomfortable. You would note that the patient was quite tender on light palpation, and then, deep palpation was not attempted. Something to that effect. In terms of using your hands to assess the temperature of the skin, it's often more appropriate to use the back of your hand, which is known as the dorsal surface of the hand, to check skin temperature. Percussion is the technique that I mentioned is generally used more by advanced practice nurses, but I just wanted to point out to you the two types of percussion. There's direct percussion, where the examiner uses their finger directly on the body part to be percussed. And the picture on the left, the examiner is percussing the sinus area to elicit tenderness, which can sometimes help with determining if the patient has a sinus infection. And the picture on the right is known as indirect percussion, where the examiner places their non-dominant hand on the patient's body part that's going to be percussed, and then takes their dominant hand, usually it is the middle finger, and percusses on top of their finger, which is on top of the patient. And the sound is transmitted through their finger, and that's considered indirect percussion. And as you can see, it's a common method of percussing the abdomen and chest area. Auscultation is an assessment technique that you're probably very familiar with. Nurses certainly use their stethoscopes frequently to auscultate for the function of various body systems. And one of the most common areas that we auscultate are the lungs, the abdomen, and certainly the heart. And certainly for manual blood pressure, you would be auscultating the artery to assess for the sounds of the pulse in measuring a manual blood pressure. During auscultation, you want to make sure that you're paying attention to the sounds that you're hearing so that you can describe them accurately in your documentation. You want to pay attention to the intensity, how loud or soft or high-pitched or low-pitched the sound is, how long the sound lasts. For example, if it was a heart murmur, is it a brief, early in the systolic phase murmur, or a holosystolic murmur, meaning it lasts throughout the whole of systole. The quality of the sound that you're hearing, words that describe exactly what you're hearing, like crackles or rails. The pattern of what you're hearing, is it a regular pattern or an irregular pattern? Is it particularly quick or slow? Is it normal? So these are the kinds of things that you would be documenting on whatever sounds you are particularly listening to. It's important to remember to put your stethoscope in the correct way. I often see nurses put their stethoscope in backwards, and you cannot hear well when you do that. The ear tips should be pointing towards your face, okay? So the way she has it here, she's about to put it in correctly. And a stethoscope conducts sound, it does not amplify it. There are amplifier stethoscopes which you can buy if you have hearing difficulty, but a regular stethoscope is not an amplifier. It just conducts the sound directly into your ear. And it also blocks out environmental noise. And so if your patient or the family member is talking to you while you're auscultating, you're not going to be able to hear what they're saying. So it's important for you to let them know that, because they may, feel they have told you something important and you didn't hear it. Sometimes I'll say to parents, okay, I'm going to listen to him now, so I won't be able to hear anything you say. And then if there's anything you want to tell me, if you could just wait and tell me after I'm done listening. Or if I don't say that and I start listening and I can tell the parent is talking to me, I'll kind of put my hand up and say, like, no, put my finger up like 1 minute, please, until I'm done listening. And then I can, you can tell me what you need to say. Whatever it is that you need to perform, whatever type of physical assessment that you need to perform, you need to think about which equipment you are going to be using, and you want to gather that equipment ahead of time so that you aren't running back and forth. That's sort of common sense, but sometimes you just need to take a couple of minutes to really think about what you need and bring it in with you. If you're rushing around, you may forget. If you're doing an admission assessment, a lot of times you need to bring more things with you because you're going to do a complete physical assessment, a scale, flashlight, vital signs equipment, sometimes a tape measure, and other things. So just make sure you're thinking about what you need before you go in the room. Make sure when you document your findings that you are clear and specific, and you can document your findings by the 4 types of techniques. So if you perform inspection, you can say, skin clear to inspection, skin warm and dry to palpation, etc. So you can be very specific in your documentation. Heart, regular rate and rhythm to auscultation, and that would be opposed to palpation of pulses. Certainly if you're palpating a pulse, you can tell if it's regular or irregular. If you're listening to the heart, you can tell as well. So sometimes it's more clear if you actually document what you're saying and how you obtained that particular assessment. Moving on to the head and neck, begins with a general inspection. So the examiner is sort of looking generally at the patient, looking at their face, looking for symmetry, looking at their hair. When you're looking at the hair, you're looking for color, consistency, distribution. Is it a normal distribution? Are there areas of hair loss? You're looking at the patient's level of hygiene. If you're looking for any asymmetry, any swelling, puffiness, signs of trauma, etc. And again, you're documenting this as well. Then you move on to palpation. So the examiner has gloves on. That's a personal choice because you aren't necessarily going to be exposed to body fluids in the palpation of the head, but if there are any lesions or rashes or open areas on the scalp, then you certainly would want to protect yourself. You are going to feel the hair and feel the consistency of the hair. Is it particularly dry and coarse, or is it oily? You want to look behind the ears, at the nape of the neck, especially if the patient's complaining of itchiness, because those are the locations generally where lice are found, behind the ears and at the base of the scalp. You want to be also looking at the eyebrows, the eyelashes. Some patients actually pull out their eyelashes. It's a anxiety stimulated activity. So just basically you want to feel the scalp for any lumps, bumps, areas of bogginess or swelling, any potential signs of trauma, etc. Moving on to the eyes. You want to get a general review of the normal anatomy of the eye and the normal terminology, medical terminology of the area. I'll point out a couple of things. Notice the lacrimal sac is the location where tears drain into, but the lacrimal gland is where tears are made and where they enter into the eye, and then they drain through the lacrimal canal and then into the nasolacrimal duct, and that's why we get runny noses when we cry. Make sure that you know what the limbus is, which is the edge of the iris, the sclera, the conjunctiva it lines the eyelids as well as covers the sclera, the iris, and the where's the lens, which I think we can see in the next slide, through the cornea. So this is lateral view, which you can see the different parts of the eye this way. So you just want to make sure that if you are seeing any abnormalities in the eye, you are describing them in the correct location. When you're doing a subjective assessment for eye problems, you want to make sure that you include specific questions in the past medical history about eye conditions, whether they ever had any eye surgery, whether they have any allergies, like environmental allergies that manifest in their eyes, like allergic conjunctivitis. Do they wear any prescriptive lenses, corrective lenses? Some people wear contact lenses, some people wear glasses. You want to ask if they ever have to wear eye protection, depending on what they do for work. Sometimes eye protection is warranted. Even nurses, we have to wear eye protection when there's ever a chance of any splashing of body fluids into our eyes. So you want to make sure that your patients are using the correct eye protection. So people in certain types of industry, construction, etc., have to protect their eyes, and certainly athletes and young athletes. So kids who are playing lacrosse or other types of contact sports often have to wear eye protection, or need to have special type of glasses. If they need to wear glasses, they need to wear glasses that will not shatter during contact sports. Are there any medications that can affect their eyes? Do they have any medication specifically for their eyes? And any family history of any eye disorders? There are some also, you want to make sure that you find out about any general chronic conditions, because there are certain chronic conditions which have some manifestations in the eyes, such as diabetes. The poor circulation associated with diabetes can cause eye problems, as well as patients with sickle cell anemia who often have interruptions in their perfusion can end up with eye conditions as a result of their chronic illness. One of the forms of physical assessment for the eye will be the eye movement. And the eyes moving medially towards the nose is adduction. Moving away from the nose laterally is abduction. And you also want to make sure that the eyes can move up elevation and below depression. So these are considered the 6 cardinal fields of gaze, and it's important for you to assess your patient's eyes for that ability. Problems with that can be related to cranial nerves, which operate those types of muscular movements of the eye. This is an older gentleman who is performing a visual assessment. So his vision is being tested, and generally they test each eye separately so that you can determine which eye has the deficit, if there is one. This chart that you're seeing on this slide is known as the Snellen chart. It's a distance vision assessment, and it's what most people use to screen for visual disturbances. Is we generally screen for distance vision. Certain age-related issues are that when patients reach usually around the age of 40 or later, they become extremely farsighted, meaning they see well far away and poorly up close. And that's why you see people like me wearing reader glasses. We call them cheaters, because we need them to read. After a certain point, it's hard for us to focus and read small print that's close to our eyes. We don't need glasses for far away, but we need it for close up. Moving on to the ears. Again, this picture is from your textbook. It's just a general overview of the anatomy of the ear and the different parts of the ear. The ear is basically divided into 3 parts: the outer ear, which includes the ear canal; the middle ear, which is behind the tympanic membrane, also known as the eardrum; and then the inner ear, which consists of the bones and nerves. Hearing loss is a problem that we would need to assess for when we're performing an assessment of ears and hearing. And there are 2 types of hearing loss: conductive hearing loss, which means that something is getting in the way of the transmission of the sound wave from where it originates to where it would be received in the inner ear. So things that can interfere with conductive hearing loss can be something that's blocking that passage, such as impacted earwax, or even a middle ear infection, because if there's a lot of fluid or pus or thick mucousy discharge in the middle ear, then the sound wave is going to be muffled and will not actually reach the inner ear well. Sensorineural hearing loss would be a problem that's related to the nerve, the acoustic nerve. That is a cranial nerve that transmits the sound wave into what we actually hear. So those are just two types of hearing loss. One of the ways to assess a patient's hearing is to perform the whisper test, and this is what this examiner is doing here, and you will get to the chance to perform the whisper test on Tina when you assess her HEENT body systems. A visual assessment of the ear, the external ear, includes the various parts of the ear. The outer ear is considered the auricle, and then there are specific parts of the auricle, including the top of the ear, which is the helix, the inner, the first bump, the antihelix, etc. The only ear part that we really talk about specifically, in my experience, is the tragus, which is that little bump right, at the edge of your cheek where your ear begins, and the earlobe. Moving on to the nose, sinuses, mouth, and throat. This is a picture of the sinuses, and you'll note that the frontal sinuses are above the eyebrows, the maxillary sinuses are on either side of the nose, and then the smaller sinuses are deeper, sort of in between the eyes. Sinusitis can occur. It would be an infection inside the sinuses. It's not something that's easily diagnosed because the sinuses are deep in the head and we are unable to visualize them. However, we can use other techniques such as palpation or percussion to assess for pain over the sinus area. That still doesn't necessarily confirm that there's an infection, because even if the sinuses are just clogged, they may be tender. But just, a general review of where the sinuses are. Subjective signs of sinusitis would be halitosis, which is bad breath, morning cough, and productive cough, especially in the morning, where pus or mucus would drain into the back of the throat all night and then cause a cough in the morning where all that mucus is produced. The outside of the nose, just so you know that the bony part of the nose ends about the middle area of where the nose sticks out there, and the rest of it is cartilage. The nostrils are referred to as nares, and the tip of the nose. In the oropharynx, you should review the different parts of the oral pharynx so that when you are examining the inside of somebody's throat, you can describe exactly what you're seeing. If you're seeing a lesion, you want to note where it is. So the hard palate is behind the teeth, and then towards the back of the throat, towards the uvula, is the soft palate, and the uvula is the little projection that drops down in the middle. The back wall of the throat is considered the posterior oropharynx. The tonsils are sort of nested in under that soft palate on either side. And tonsils normally increase in size in childhood to the point where they're about as big as they're ever going to get between 8 to 12 years of age. During adolescence, the tonsils start to shrink. So in adults, you generally cannot visualize tonsils even if they were never removed because they shrink in size. You want to make sure you're looking at the gums, the frenulum of the upper lip, frenulum of the lower lip, the vestibule of the mouth, the space between the lip and the gum area. The gums are referred to as the gingiva, the dorsum of the tongue, and the teeth and lips. Often examiners will look at the ventral surface of the tongue, underneath the tongue, because oral cancers will originate there in many cases. There are some ducts there, And as you can see, it's also a very highly vascular area. So whenever there's a tongue injury, there's usually a lot of bleeding. This is just a picture of the normal papillae on the tongue. There's been a couple of times when parents have actually brought their children in to see me because they think their child has something wrong with their tongue, because they all of a sudden see those bumps and they never noticed them before, and they think that there's a problem, when actually those papillae are normal and they normally appear in the very rear of your tongue. If you open your mouth really wide, you can see them. Just a reminder about dentition. If you're ever examining the mouth and throat of children, the primary teeth, which begin to erupt, usually they begin to erupt any time between 6 and 12 months of age, and they continue erupting up until about 6 years of age, and there are 20 primary teeth. Then in the order that they erupt, they begin to fall out, and then the secondary teeth come in, and there's a total of 32 secondary permanent teeth. 20 primary, 32 secondary permanent, and those include the wisdom teeth. This is one way to examine the buccal mucosa, which is the inner lining of the cheek, by taking a tongue depressor and sticking it just inside the lip and pulling outward, pulling laterally, and that pulls the cheek away from the teeth and gums and allows a clear visualization of the area around the teeth and inside the cheek. So that is a good technique to use. In this case, the examiner is placing the tongue depressor on the tongue in order to get a good visualization of the oropharynx. You can see the uvula there. It's a nice dull pink color. It is not bright pink. It is not deviated. It does not look swollen. It looks normal. The only problem with using a tongue depressor, it can sometimes make people gag, and it makes them resist opening their mouth. So I always try to visualize the oropharynx without a tongue blade. I'll ask the patient to stick out their tongue and say "ah" as loud as they can and open as wide as they can. And I really avoid using the tongue blade, because as soon as you put the tongue blade down on the tongue, it causes them to sort of do the opposite of what you want, which is resist opening your mouth. And I'm ending on this slide, which is a picture of strep throat. This is a classic presentation of strep throat, and you notice the difference between the previous slide and this slide. You can see how bright red the soft palate is and the uvula and tonsils are. And notice the little red dots that are progressing up the soft palate. Those are petechiae, or broken blood vessels, that appear on the soft palate. So a petechiae on the palate, a bright red pharynx with a swollen red uvula, is a classic sign of a strep infection. It's very angry looking. And it's an indication of a bacterial infection. So if you ever saw a throat like this, you would definitely want to make sure the patients had a throat culture. So that's all I'm doing for this body system assessment. It's just a review of what you need to look for, the questions you need to be thinking about asking. And if you have any questions or concerns about this week's content, just let me know.